Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Doctors Dease and Lexy Regush, an anesthesiologist and obstetrician-gynecologist, respectively, in Saskatoon, Saskatchewan, discuss non-obstetric surgery for the pregnant patient. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Welcome to Grand Rounds for November 2024. This week it's multidisciplinary. We have people here from anesthesia, obstetrics, and some of the other surgical specialties. Thank you all for tuning in. This is a very important topic. My name is Dease. I'm an anesthesiologist from Saskatoon, and I'm co-presenting with Dr. Lexy Regush, who is an obstetrician from Saskatoon. These are the objectives of my talk. Dr. Regush will cover probably the most interesting part of this topic, which is when and where these patients should have surgery and where they should go afterwards. This is what I will talk about before handing off to Dr. Regush. So my objectives will be to cover the physiological changes of pregnancy and why they can make anesthetics more challenging. Not all anesthesiologists look after pregnant patients regularly, so I want to do a little review for them. I want to briefly touch on the teratogenicity of anesthetics. Spoiler alert, there sort of aren't any. We'll dispel some dogmas. We'll talk briefly about changes in fetal heart rate under anesthetic, but Dr. Regush will cover most of that. And we'll discuss some anesthetic options, breastfeeding considerations. There are almost none. And a little bit about what to do when things go very badly. All right, so these are the 5 most basic considerations for doing a general anesthetic on a pregnant patient. This is what you'll learn on day 1 on your obstetrical anesthesia rotation. These patients can have a difficult airway, they can desaturate faster, they have an increased risk of aspiration, they have an increased risk of hypotension, and there's some considerations for the fetus. So what about the airway? Well, much of the airway edema and swelling occurs in labor. The books say that the Mallampati score can get worse by a degree or 2. Hopefully you won't be dealing with a patient in labor in these situations, so hopefully you won't be faced with as bad of an airway. What about respiratory changes? Well, by mid-pregnancy, the functional residual capacity can drop by as much as 25% as the uterus expands and weight gain occurs. To make matters worse, oxygen consumption is also increased, so this can lead to a rapid desaturation and hypoxemia. Here's just a picture of a graphic illustration of how the enlarged uterus can push on the diaphragm and push on the lungs and decrease the FRC. So pre-oxygenation is absolutely vital in these patients. The pregnant patient's minute ventilation is actually increased, and their PCO2 is lower than in the non-pregnant state. So you want to keep these patients where they live and not let their PCO2 rise too high. Avoid hypoventilation. What about cardiac changes? Well, cardiac output increases by up to 50% during pregnancy. There's increases in heart rate, increases in stroke volume, and there's a drop in the SVR. These changes begin at 8 weeks and are typically maximum by about 24 weeks. These changes increase dramatically in labor and after delivery, but again, we won't be dealing with that. So our cardiovascular changes in the pregnant patient in front of us shouldn't be quite as great as they would be if you're taking care of a patient in labor. From about 20 weeks on, there is progressive compression of the IVC by the gravid uterus, and this reduces venous return and cardiac output. So you should perform a left lateral tilt from about 20 weeks on or so. Some studies, interestingly, are calling this into question, but it's still highly recommended that we do this. What about gastric changes? Well, again, due to the pressure from the uterus pushing up on all the organs, as well as progesterone-induced changes in the lower esophageal sphincter, there's increased risk of aspiration by about 18 to 20 weeks. This will go away about 48 hours postpartum. So if you have to put this patient to sleep, you should probably do a RSI with a tube. Hematologic changes, these are actually really good for us. They make it easier for the pregnant patient to tolerate blood loss. Pregnancy is a hypercoagulable state. There's increase in fibrinogen and other factors. This is interesting. The fibrinogen levels are the lab indicator most closely correlated with severe complications. So you should try to keep the fibrinogen above 2 at all times. The fibrinogen levels are sort of a general indication of badness. So again, this is a summary of the physiological changes of pregnancy that can make doing a general anesthetic more difficult airway, faster desaturation, increased risk of aspiration, and increased risk of hypotension. Notice that I didn't really talk about the considerations of the second passenger, and that is intentional. Dr. Regush will get into the things we need to do to keep the baby safe, but generally that are good for mom are also good for baby, okay? And this is important. If the baby isn't going to be born, we don't have to worry about fetal respiratory depression from opioids, and we don't have to worry about the decreased uterine tone from our anesthetics. We focus our attention in these situations on keeping the mom in the best condition possible. What about our anesthetic drugs? Well, pregnant patients generally need less general and less local anesthetic. There's a number of reasons for this that I think are sort of beyond the scope of this talk. This can be variable, and pregnant patients also have fairly high rates of awareness under general. This greater risk of awareness under general is probably strongly related to the situations that these patients get general anesthetics in. But in spite of that, titrate your anesthetics to some sort of effect whenever you can. That's always a good practice. What about teratogenesis? Well, spoiler alert for Lexy's talk, but the biggest risk to the fetus in the perioperative setting is poor or delayed care of the mom. Okay, that's the big lesson from our talk today. Information about human teratogenesis is generally unreliable. This research is based on 3 things: small animal studies. In these studies, often very unreasonable doses are given to animals, such as giving a starved pregnant rat running on a wheel 6% sevoflurane for 48 hours. The studies are also based on epidemiologic studies of OR personnel and population-based outcome studies. We don't really have any high-quality studies. Also, the considerations of the possible teratogenesis of anesthetic agents must be viewed against the naturally high occurrence of adverse pregnancy outcomes. And this is also somewhat unknown, so we don't really know what the denominator is. This is basically all you need to know. This is from the American College of Obstetricians and Gynecologists. At standard concentrations, no current anesthetic drugs have demonstrated teratogenic effects on humans at any gestational age. Okay, so that's very nice that they came out with that statement for us. Well, what about benzodiazepines? It used to be taught that benzodiazepines were prohibited in the pregnant patient in the OR. This is not true. This little piece of dogma was based on this terrible study from 1984. You can't even get the abstract for this anymore. In this study was based on, it was a small retrospective analysis of psychiatric inpatients, and these patients were taking long-term diazepam. This was not like a single dose of Versed in the operating room. The patients were also on a lot of other psychiatric drugs, and this bad study showed a link to cleft lip and palate. There is really no evidence that a single dose of benzodiazepines is harmful. This recommendation about avoiding them for the first 9 weeks is mostly about patients with anxiety disorders who might be taking benzodiazepines on a daily basis. Our nitrous oxide, that's okay. There was some studies about long-term exposure of pregnant OR personnel to nitrous oxide, which is that's a different group of people than what we're talking about, a single exposure in the operating room. What about choices of anesthetics? Well, there's really no studies that show any significant differences in maternal fetal outcome during a non-obstetric surgery in the pregnant patient. But generally speaking, it's probably a good idea to do a regional if you can. And if you do have to do a general, you should intubate the patients if they're over 18 weeks and less than 48 hours postpartum. What about fetal heart rate monitoring? Well, again, Dr. Regush is going to cover most of this, but I will cover on a little bit of the anesthetic aspects of fetal heart rate monitoring. If you are doing a case and you're monitoring the fetal heart rate during the operation, you have to remember that the greatest risk to the fetus is the same things that are great risk to the mom, generally speaking. Things like placental abruption, of course, can be catastrophic for the baby, but outside of that, if you're taking good care of the mom, generally speaking, you're taking good care of the baby. Same theme again. If you're doing fetal heart rate monitoring, volatiles and our other drugs can cause drug-induced changes to the tracing. The drugs will cross the placenta. They will lead to a decreased fetal heart rate variability as the fetus becomes anesthetized. This is not a cause for concern. Decels should not be seen, however, so that is something worrisome. Generally speaking, though, you can use the fetal heart rate tracing as an auxiliary monitor for the state of the mom. Once again, remember, fetal respiratory depression is only an issue if the fetus is delivered, which is hopefully not going to happen. Some other drugs that you might read about with respect to fetal heart rate tracing are muscle relaxants and reversals. Atropine will cross the placenta and could cause fetal tachycardia and loss of variability. So you might have to be aware of that. If you use glycopyrrolate instead, that will not cross. So that's good. But neostigmine will cross, and that could cause fetal bradycardia. So some obstetric anesthesiology literature talks about giving atropine with neostigmine. But generally speaking, I don't think this is really a major issue. Here are some things you can do if you're doing fetal heart rate monitoring and you have a bad tracing. Notice once again, outside of doing increased bed tilt and maneuvers to relax the uterus, mostly what you're doing is treating the mom and keeping her in good shape. The final drug I'll talk about is Sugamidex. This is pretty interesting. This is a relatively new drug that we use to reverse muscle relaxation. It has no effects on fetal heart rate, but it has some pregnancy considerations. It encapsulates progesterone. There is not much literature on this, but we do have some recommendations from the Society of Obstetrical Anesthesiology Providers. They say that you should probably avoid this in early pregnancy because progesterone is necessary to keep the pregnancy going. Later on in pregnancy, the recommendation is to avoid or use with caution. If the patient is postpartum and has established lactation, it's probably okay to use. And their final recommendation is rather nebulous. Give it if you think the benefit outweighs the harm. What about breastfeeding? Well, again, no major issues here. This is a statement from the Society of, from the American Society of Anesthesiologists. Basically, it's not a major consideration. They don't recommend that you pump and dump. As kind of a general motherhood statement, they do recommend that we try to reduce the amount of opioids we give these patients. And again, that's just a general good idea, no matter who you're taking care of. Finally, I want to talk a little bit about trauma surgery. This is very disappointing. Trauma is the leading cause of non-obstetric death in pregnancy, and domestic violence is the #1 cause, followed by motor vehicle accidents. Once again, if you're faced with looking after one of these patients, treat them as you would a non-pregnant patient with some special considerations to the risk of abruption. And again, except for factors specific to the fetus, if you're taking good care of the mom, you're generally taking good care of the baby. If you get into a code blue situation, there's a couple important things to remember. It is important to do a perimortem C-section within 5 minutes of loss of a heartbeat. Other than that, most of the ACLS recommendations are the same as the non-pregnant patient. If you do have to do chest compressions, you do not want to have the patient tilted. You put the bed back to just flat, and you have a dedicated provider pulling over the uterus off the IVC while you're doing compressions. And then, of course, they'll stop that if you have to do a C-section.
Okay, my objectives today, I think we'll run through case themes. We're not going to run through specific cases. However, when we take a look at what we have concerns raised to us about, they generally fall into a few different categories. We'll go through the evidence and the recommendations regarding fetal heart rate monitoring in the perioperative period. We'll go through the policy that has been in place here in Saskatoon regarding the care of these patients, and then we'll save time for discussion. So this is a fairly common thing that we do hear about when we get our quality and safety questions brought to us, and they generally fall into a series of themes. Monitoring for labor in a postoperative patient with peritonitis, delays in the surgery occurring in the first place, which then of course leads to peritonitis. And as we'll talk about, peritonitis is actually a huge problem in terms of risk of pregnancy loss. So delaying an appendicitis being treated is actually a really big deal in pregnancy. Poor pain control, and a lot of this is due to apprehension or fear of narcotic administration, maybe by people who don't interact with pregnant patients on a regular basis, and a lot of discomfort and distress amongst staff providing care at a center that maybe doesn't have a maternal team or an NICU in the building because of what ifs. And if you what if enough, you can get your head into a really uncomfortable space. And unfortunately, patients are really attuned to this. They feel what's going on around them, and they often feel they aren't welcome or wanted in that center, which unfortunately leads to a really negative experience for them. But interestingly, despite all of this, in terms of non-obstetric surgery, I couldn't think off the top of my head of any intraoperative cases with reports on safety. Certainly we do in the obstetric OR, but that's a different situation. We have obstetric things going on and a different level of pregnancy-related risk. But in terms of the non-obstetric surgery, I couldn't think of any intraoperative disasters that had come to us. And again, I think that it's really important here that this reflects on the patient experience and that it often is very poor. A lot of the patients will report back to us that they had this poor experience that gave them a lot of significant distress and affects their mental health. And unfortunately, some will even say that it'll impact their decision on whether or not they have any future pregnancies. So what is it that worries us? And I think that we have a group of people here who is really committed to doing good work and caring for our patients well. Otherwise, why would you do these jobs if you didn't really care to do that? And so these are a bunch of good people who are worrying about doing something that may cause harm. They worry about causing harm to the baby, long-term health consequences to the child. Like, what if it has cerebral palsy because I did this? Or what if it has, a cleft lip because I gave one dose of a benzodiazepine? They worry about doing something wrong and causing a miscarriage or stillbirth, about doing something that causes the pregnancy to suddenly deliver and then being caught unprepared for that event. Or what if she codes? Who's going to do the perimortem section? And there's lack of comfort with the care of pregnant women as a unique population, and just not maybe a lot of experience with what is standard care in that kind of a population. So What if narcotics cause the baby to be addicted? What medications are safe? I know that this doctor has ordered it, but is it really safe? And should I give it? And is that going to be my license? How does a pregnant woman get assessed post-operatively? So with this discomfort, what we tend to do as human beings is we do try to avoid the situation, and then the default becomes under treatment. And again, and you're going to hear me say this about 10 times, the greatest risk that women face in pregnancy with medical care is under treatment. So when we look at data in pregnancy, there was traditional teaching. And I mean, any of you that have been around when Dr. Keith was doing training back when I was a resident in medical school, I mean, those guys had a lot of really dogmatic teaching about surgery and pregnancy and how dangerous it was. And it was to be avoided at almost all costs. There's risk of pregnancy loss, the teratogens, but all the data is old, and really, who is our control group? So most of our current knowledge comes from years of just having had to do it, to deal with these situations and then look back and see how things have gone. And again, to support what Marie said, no evidence of teratogenicity. And the consensus is generally that medically necessary surgery should not be delayed. So when we look at how common surgical care in pregnancy is, about 2% of women will require surgery during their pregnancy for some reason. So if you extrapolate that out, 5,400 deliveries a year at JPCH means roughly 110 of those women will have had a surgery in their pregnancy. Now, we're a tertiary care center, so we are going to see maybe a little bit more on average of that, as we'll see the cerclages. It's a trauma center. The complicated abdominal stuff is going to come to us, as well as JPCH is the catchment for the northern half of the province, as it has the level 4 NICU. So urgent or emergent care should be offered with appropriate modifications for the gestation. But truly elective surgery could be delayed, if it's hardware removal or something cosmetic. But again, just to put my foot on another little soapbox here, that's why all women of reproductive age should have a pregnancy test at presentation for surgical care. Sometimes you don't know if you don't look, and if somebody is going to come for something elective, they should have the opportunity of at least knowing that they're not pregnant, or if they are, and they can have that opportunity to defer. So what's common in terms of non-obstetric surgery? Well, appendectomy is the most common cause for a woman to require a surgery in pregnancy, followed by cholecystectomy. But then there's another whole host of things that kind of come about, just as people normally live and things happen. So there's traumas that happen, and unfortunately intimate partner violence, and we've seen a great escalation of that in the last few years. Just because you're pregnant doesn't mean you can't get cancer. We certainly see people who require surgery for those things as well. Urology is a fairly common place that our patients end up requiring stenting for hydronephrosis or removal of stones. Gynecology, we do frequently see ovarian cysts that need to be removed, or an ovarian torsion that needs to be detorted, or that ovary sometimes taken out. Cervical cerclage, most of the time will be a vaginal approach. Sometimes will be an abdominal approach, laparoscopically or open. Myomectomy is quite uncommon in our center in pregnancy. However, it was not unheard of to do those things in pregnancy, as well as the non-abdominal things like dental, orthopedics, and plastics. So any emergent or urgent care should be undertaken, and the greatest risk is delay. If you look at an appendicitis, there's a 3% risk of fetal loss. But if you have a perfed appendicitis, you're looking at a 36% risk of loss. So delay is really a big deal in that particular situation. Even urosepsis, if you have an infected stone or a pyelonephritis with hydronephrosis of pregnancy, urosepsis will put a pregnant woman in the ICU rapidly. So getting that done in a timely way is really important in terms of ensuring her overall well-being and thereby the well-being of the pregnancy. And I really thought this was interesting. 1908, in the Journal of the American Medical Association, Edmund Babler, the mortality of appendicitis complicating pregnancy and the purpurium is the mortality of delay. So 116 years ago, we had it published that we should not be delaying these things in pregnancy. The delay in diagnosis and resolution of that is, the delay in resolution is the greatest preterm labor risk, not the surgery. So appendicitis and appendectomy had a bad rap, but why is that? It's all about peritonitis. Peritoneal inflammation is a huge trigger for preterm labor. And again, we do need to treat these women well and expeditiously and comfortably as healthcare providers, because this is a really tough experience for women. Nobody on their Instagram page has the time they had appendicitis and ended up with a drain in their belly. So it's a bit of a delicate time, and people are at risk of mental health challenges, and a long stay in the midst of a pregnancy gives a high risk of postpartum depression. And so I think we can suffice to say that the right treatment outside of pregnancy is almost always the right treatment in pregnancy, but the right treatment for the pregnancy is always going to be proper care of the mother. And that means timely access to the OR, adequate pain control, and antibiotics. So in terms of abdominal surgery in pregnancy, I'm not sure who's here from a regional center. There may be things that are safe in a regional center, but there's a time when things really should come to Saskatoon instead. Sometimes it has to do with skill sets available at each site and the frequency with which you may see a procedure or a situation, as well as experience with perioperative care and ability to handle complications. Gestational age is a decision-making factor there, as well as something in the first trimester, of course, is going to be very different in terms of complications that arise in the third trimester. But also we need to consider the delay. If there's a huge snowstorm and you can't get someone from PA to Saskatoon and it's going to delay your appendicitis treatment by 8 hours, is the right thing to actually get the appendix out in PA and then send it to Saskatoon? Those discussions really do need to be had and things considered. So let's take a look at what there actually is in terms of outcomes in the literature. So this goes back almost 20 years to 2005. It's a systematic review of the literature, but the range in that literature is from 1966 to 2002. So it's 54 papers, over 12,000 patients. The miscarriage rate among patients was 5%, and up to 10% of surgeries in the first trimester. Stillbirth was approximately 2% of surgeries with premature delivery in 8. However, again, where's our controls for this? Well, there aren't controls. So are you going to compare pregnant women with appendicitis to pregnant women who did not have appendicitis? Well, there's no comparison there. Are you going to compare them to women who didn't have treatment for appendicitis? Well, that's no way to compare either. So this is really old data. There's a wide range of care improvement. In 1966, NICUs were probably just starting to exist. In terms of, so the range of perinatal care has changed. What was a stillbirth in 1966 is now very much a viable neonate for us now, as the age of viability has gone down. Antibiotics are better, surgical technique is better. There was no laparoscopy for anything in pregnancy in 1966. That wasn't until the 90s that laparoscopy was a thing, and probably not applied to pregnancy until into the 2000s. So this is over 45 years. It's not very good. And what they say is the clearest data, which is poorly controlled, exists for appendicitis with surgery-induced delivery occurring in 4.6%. However, fetal loss with peritonitis is 10.9%, which suggests it's actually the condition, not the surgery. So this, you gotta really love the UK for their data collection. They're so good when it comes, especially to maternal stuff that we just can't seem to get our hands on here in Canada. They undertook a study because there were lots of questions by women who needed to have surgery for cancer about what the impact was going to be on their pregnancy. And they wanted to know about things like miscarriage, stillbirth, premature delivery, or problems following the delivery. And they realized that there really wasn't any good evidence and that there was a huge knowledge gap. So in that population, 0.7% of women had surgery in pregnancy, and they found that there was one additional stillbirth for every 287 procedures, one additional low birth weight infant for every 39, one additional preterm delivery for every 31 procedures, and one additional maternal death for every 7,692. But again, there's no data on what would have happened without those procedures, and all of those outcomes would have been anticipated to be much, much worse. So we've got another study here from 2017, looked at data from 2002 to 2012, so a little bit more modern in terms of our NICU care and our surgical care. Looked at 6,400,000 pregnancies, and there was surgery in 47,000 of them. And at the end of the day, what they came out with was that the risk of an adverse birth outcome following non-obstetric surgery and pregnancy was low. However, a key limitation is being able to separate the risk of surgery from the condition itself. One of the more recent ones, 2023, a Scandinavian Journal of Surgery looked at the non-obstetric surgery and the effects on outcomes. They looked at 80,000 women who underwent non-obstetric surgery and compared with the 16 million who did not have surgery during their pregnancy. They looked at articles that were published between 2000 and 2022. But if you actually look at those articles published, the cases that they report on go back as far as 1980. So in 1980, the lower limit of viability, for example, would not probably have been 24 weeks and probably would have been closer to 27, 28 weeks. So we're looking at very different neonatal care and certainly different surgical technique. 17 of these studies were prior to 2000. So a good bulk of those cases weren't actually super modern in terms of care. So the prevalence of non-obstetric surgery was 0.2 to 0.7% out of all of their pregnancies, with appendectomy being the most common procedure. Almost half of them were in the second trimester, 32% in the first trimester, and about a quarter in the third trimester. Half of them were scheduled surgeries, half were emergent. They used laparoscopy and open techniques roughly equally. So again, women who underwent non-obstetric surgery had an increased risk of stillbirth and preterm birth. However, this did not increase the risk of miscarriage, low 5-minute APGAR scores, or the fetus being small for gestational age, or any congenital anomalies. So it's always a hot topic, and I expect it will be a hot topic even again today. But fetal monitoring is one of the things that is very frequently discussed when we are planning a patient to have operative care. Now, not all of you do a lot of fetal monitoring because it's not really part of your practice. So just to get back to some of the basic principles, fetal heart rate monitoring is not really about a standalone fetal heart rate at a period of time. What you need to know is what is normal for that period of time and what an ongoing pattern is and what the likely environment is for that fetus at that point and what their reserve is to be able to make an interpretation of what is actually going on and what could be changing with that pregnancy. So when we look at a fetal heart rate, it's not just that it's 130, is there beat-to-beat variability? Are there big drops or rises in that heart rate from baseline? And is that baseline staying the same or is it shifting? And how does this relate to what's going on with uterine activity? So this is done in a longitudinal fashion. And basically our goal is to decide which fetus is at risk of hypoxia. And so why do we care? Well, we've got two major concerns. We want to avoid fetal death, but we also want to identify who is going to benefit from early intervention with resuscitation, intrauterine, or who requires delivery. So what's the normal monitoring preoperatively? Well, an NST can certainly be considered depending on the situation and the maternal stability. If you have a trauma come in, you might not really have time to get a good NST before you go to the OR because you have an aortic laceration. But, this shouldn't necessarily delay emergent surgery. But if you have a mother that isn't that stable, but isn't something catastrophic, like an aortic thing, then an NST can be helpful for you to interpret what may be received by the fetus in terms of that instability. So there's a lot of things that need to be considered with that, medications that she's received, whether or not she's had opioids, her condition, the nature of her illness, and the gestational age. Now, for most given situations, so if we take our ever common appendicitis, most of the time, a pre and post-op fetal heart rate is going to suffice. If there isn't peritonitis and contractions, really, the fetus doesn't really have much going on. If the uteral placental unit is well perfused, then as far as that pregnancy is concerned, it's going to be okay. So the fetal heart rate alone doesn't give enough information for making a decision, really, unless you're in the situation of a terminal bradycardia. The changes in the patterns are going to exist due to medications. And even when we look at the same strip, either several experts or the same expert over multiple times, there's always issues with reliability and there's high false positive rates. So we have to be really careful about this, or we will end up causing harm by unnecessary iatrogenic preterm delivery for states that are actually just transient responses to that condition or the situation at that time. Our better approach is to optimize the fetal heart rate intraoperatively. And how do we do that? Well, we take really good care of that mom. We optimize the environment by making perfusion of that placenta good with good positioning, with tilting as needed, keeping the maternal hemodynamics stable, minimizing large changes in terms of blood pressure, and maintaining good maternal oxygenation. It's the best way to protect the fetus in its environment, and it should be the focus really of our efforts. And Murray went through this. We're not going to talk about how to improve perfusion, and you guys are all experts in that. So perioperative fetal monitoring gets to be a little bit contentious from time to time. We often will offer a fetal heart rate pre and post-op, mostly to be reassuring to the patients and staff. What's the first thing that a pregnant woman will often say when she's half awake coming out of her anesthetic? It's is my baby okay? And it really just allows people to say yes. Now, it's a little bit of a loaded statement. Again, is a single fetal heart rate really an overall assessment of a pregnancy? No. Was the fetal heart there at the beginning and at the end of surgery? Yes. Which is information. But to extrapolate that a lot further, we just don't really have good grounds for that. So meaningful predictive fetal monitoring has to be done by somebody who's trained to interpret that. It's like me reading ECGs. You don't really want me reading an ECG. I can tell you basics, the heart rate, it's there, but to make interpretations on that's not something that I am skilled at. So the fetal heart rate tracing would have to be done to show patterns. You need to have somebody who understands the effects of medication, the anesthetic, as well as gestational age norms. And you really need to have a reason to do so with the ability to act if the monitoring is grossly abnormal. You know, to do this at 22 weeks when there's not really a point to delivery, as it's not a viable gestation, it's not a meaningful thing to do. It's not something we should do and causes a lot of angst. So what should we be acting on? Well, variability is going to be changes in medication in the OR. If somebody comes into our labor assessment at full term with no contractions and they have no variability, that's a meaningful thing to us because that's not normal for that situation. But to have no variability in this particular period of time really isn't that meaningful when you take the whole context. The fetal heart rate might be shifted due to maternal conditions. So fetal tachycardia, fetal heart rate of 180 is not uncommon with maternal sepsis. But are we going to deliver on that? No. In labor, that's a problem. In labor, that can be chorioamnionitis. It can be that there's an abruption. It can be all kinds of things. But in this kind of a situation, it doesn't have the same meaning that it has in a different kind of environment. Now, a terminal fetal bradycardia is probably the only pattern that should be intervened upon. Again, we're going to start with intrauterine resuscitation, and optimal maternal care is going to be the basis of fetal care. And this would be a very uncommon thing, but that might be the only thing that you can actually make a good argument for acting on in the midst of intraoperatively. So we're not going to go into a lot of detail about this, but when you take a look at a lot of the commonly used anesthetic medications, they all seem to have a bit of an impact in terms of fetal heart rate variability, changes in baselines. Even with the anesthetic, you can have some transient late fetal decelerations. And again, intrauterine resuscitation or waiting out a lot of this is really going to be the right thing to do. There was a good review done by Canadians. It's always nice to have some Canadian stuff here. A systematic review of the evidence looking at fetal heart rate monitoring in surgery, so intraoperatively. This is Higgins, Kingdom, and a group from Toronto. They did a systematic review of 4 publications, which isn't very many, and they reviewed the fetal heart rate monitoring in a total of 74 cases. Taking a look at that group, there were no intraoperative births required, non-reassuring fetal heart rate monitoring in 1 case, which was fetal tachycardia and associated with maternal pyrexia. Now, in the 48 hours post-operatively, 5% of those cases did require delivery, but intraoperatively, none of them did. So the goals of their study was to review all of the evidence around the fetal heart rate and contraction monitoring for non-obstetric surgery, and to examine fetal heart rate changes associated with the different gestations and types of surgery. So the majority of the case reports were actually excluded. There were a few case series that again go back to 1966. There were no RCTs, no cohort studies, no case controls. And of the 74 cases, 41 of them were general surgery, 13 were cardiovascular, and 20 were either neurosurgery or ortho. The median gestational age was 30 weeks, going down as low as 22 weeks and a max of 36. In 41 of the 74 cases, they didn't actually get good monitoring or didn't report on it. In 79 of the 74, they report abnormal fetal monitoring. So that abnormal, we're not talking about abnormal for intraoperative monitoring. Really, that abnormal is compared to what we have defined as normal, which isn't generally in the OR with an anesthetic on board and a disease process. So what they called abnormal was reduced variability, fetal bradycardia, most of the time with aortic cross clamping and putting people on cardiopulmonary bypass, fetal tachycardia in the case of sepsis. 1 case they tried to monitor, they couldn't. And 3 cases, they said the monitoring was normal or stable. And there really wasn't detail on the outcomes beyond good. So no birth weights, APGAR scores, cord gases with delivery and such. Looking a little bit closer, the general surgery cases go back to 1979. Were done between 23 and 35 weeks gestation, and a wide range of general surgery type cases. In terms of their outcomes, 3 of the infants were delivered simultaneously at the time of the surgery because of fetal heart rate abnormalities. So at 30, 33, and 34 weeks, which are all still preterm. 2 of them were a result of fetal bradycardia, and 1 because of reduced variability. All but 1 baby survived. There was 1 neonatal death in 1979 in an infant that was delivered 3 days after the maternal left pyeloplasty at 27 weeks gestation. And that baby died 7 weeks later. But keep in mind, the lower limit of viability in 1970 was roughly about that gestation. So neonatal care isn't comparable now to what it was then. And this was the time before steroids were given. That would have been, I believe, pre-surfactant. I'm not sure about that, Jocelyn, I'm sure we'll know. But it's very, very different. So given significant advances in OB and anesthesia as well as NICU practice, this doesn't reflect modern practice. In terms of the cardiovascular cases, they were again between 1975 and 1996. So we're talking about a long time ago. Done between 22 and 35 weeks gestation. Most were valve repairs, all delivered at term with normal APGARs except for 2 with no details on why they were delivered. And again, these cases are really getting to be quite old. 3 out of the 13 cases were reported between 2004 and 2016. 2 of them were mitral valve repairs at 28 weeks, and 1 was a resection of an atrial myxoma. Fetal heart rate abnormalities were noted in nearly all the cases, so 12 out of 13. The most common was the fetal brady at the start or completion of cardiopulmonary bypass, and in most of them, the fetal heart rate returned to normal by changing position, increasing oxygen, moving retractors, giving aggressive volume replacement, and changing the concentration of the anesthetic agent. So essentially, what the monitoring did for them allowed optimization of maternal cardiovascular parameters through improving perfusion to the uteroplacental unit by all of the general things that you generally would do. In the neuro and ortho cases, there wasn't really a lot of detail available. There was clipping of aneurysms and evacuations of hematomas and resecting brain tumors and AVMs. All were live births except for one maternal death at 60 days post craniotomy. All were live births at term except for one born at 28 weeks, and there was a maternal death there. A stillbirth at 26 to 27 in someone who'd had evacuation of a hematoma, and one preterm birth at 31 weeks in someone who had an evacuation of a hematoma. These cases were kind of varied. There was a resection of spinal TB at 26 weeks, and a discectomy or craniotomy at 23 to 24. So the conclusions of this study, which is one of the bigger ones, is still that the current recommendations to perform fetal heart rate monitoring is based on very low quality evidence, that the abnormal monitoring in almost all resolved and were delivered at term as neonates with good outcomes. So the meaning of that monitoring at that point in time wasn't really in a long-term way predictive of harm to that pregnancy. So we need to be wary of the interpretation of external fetal monitoring during a gestation, during a general anesthetic, and during cardiac surgery in particular, because a lot of people don't really know how to interpret this, and it leads to inappropriate decisions. Even with intubation, if you watch the fetal heart rate with intubation, you're often going to see a bit of a bradycardia in response to the maternal condition and changes. So the challenge that they presented is that, can we actually use our fetal heart rate principles that we use to interpret patterns in the antenatal or intrapartum periods to fetuses undergoing a general anesthetic, often at a preterm, potentially viable gestation? And when you look at that, we want to take what we use in our normal situation criteria and apply it to people with a general anesthetic, preterm, and potentially viable. That really starts to get us on the ledge of where we think, like, what are we doing and why are we doing that, unless we can really have a clear benefit to doing so. So when you look at a healthy fetus is going to have sufficient cardiovascular reserve to withstand transient hypotension or uterine activity, especially when the mother has a good oxygenation, and the volatile agents that you guys typically use generally relax the uterus, and they certainly aren't going to be stimulating. These are often very different circumstances during urgent non-obstetric surgery. They're preterm, they're not laboring, they're not the kind of surgery that we're doing in somebody who has a wild severe preeclampsia, HELP syndrome, 27 weeks, the placenta is not keeping up, and then you have an ill mother. These mothers are different. They don't have that issue ongoing. The observed changes in the fetal heart rate monitoring are less important than the progressive changes that we see in labor. So the meaning of these changes that we see in the OR is different than the meaning of the changes that we see in labor with a fetus under stress, and we know how to interpret that. So in the conclusion that they came to, evidence for intra-op fetal monitoring is based on case reports and case series. That maternal cardiac surgery involving cardiopulmonary bypass commonly results in fetal bradycardia, which may be challenging to interpret, and that we need to know these changes that happen are to be expected and don't justify iatrogenic cesarean section. The evidence doesn't support fetal heart rate monitoring the premature fetus during non-OB surgery. It doesn't improve outcomes, and there's a really good chance that overinterpretation and applying norms actually leads to harm. So what should we do? It can be complicated to do external fetal monitoring in surgery, technically difficult to achieve something meaningful, and we should work on optimizing the mom. Moving on to 2020, the Obstetrics and Gynecology Journal, May 2020, there was a cohort study looking at 2013 to 2019 cases, so a little bit more contemporaneous, whether continuous intraoperative fetal monitoring impacts decision for obstetric intervention, and that looks at perinatal outcomes. So when they looked at these, 4% of them, so 24 cases were performed at greater than 24 weeks gestation, ranging between well, 23 isn't greater than 24, but it's pretty close, to 36 weeks. And 56% of these cases used intraoperative continuous fetal monitoring. 2 of them required intraoperative fetal resuscitation in that group, one with a fluid bolus and one had a cesarean section. But these cases lasted quite a bit longer, so 105 minutes versus 40 minutes, so more than doubled, and were more likely to be performed under a general anesthetic at 83% of them versus 26% of them. What the continuous intraoperative fetal monitoring did, though, it didn't really help. It didn't have an association with the non-reassuring monitoring postoperatively, and it didn't really impact the average gestational age at delivery. So at the end of the day, their conclusion was that it didn't significantly affect intraoperative or postoperative obstetrical outcomes, and that this data can help to allocate limited resources and reassure providers who are able to then appropriately counsel patients about surgery. So what is there for actual guidelines? What do the societies say? SAGES and ACOG are the only ones to have opinions. The Society of Obstetrics and Gynecology doesn't really say much at all, and the Royal College, in terms of UK guidelines, gives us nothing. So SAGES says while intraoperative fetal monitoring may be presumed to be the most accurate method of fetal evaluation, the current standard of care is pre and post-op monitoring, and there's no increased fetal morbidity in the absence of fetal heart rate monitoring. At viability, it could be considered, but it should be done only if an obstetrician is available, the patient consents to an emergency C-section for fetal indications, the monitoring can actually physically be done, and the nature of the surgery is such that you can actually interrupt it or alter it so that there can be access to provide the emergency cesarean section. The American College acknowledges that it's difficult to conduct a large-scale RCT, and there's no data to allow for recommendations. And the bottom line is obtain obstetric consultation prior to performing non-obstetric surgery. One of the better papers talking about process would be this one from Clinical Obstetrics and Gynecology in 2020. This is again American, and so we have to remember there's always a little bit of a bias in some of these places. They talk about perioperative planning in terms of it being multidisciplinary, with surgical, obstetrical, anesthesia, and neonatology being present for opinions, detailed discussions with the patient about fetal monitoring, delivery, maternal preferences, and consideration of steroid administration for lung maturity if appropriate. In terms of their fetal monitoring recommendations, again, depending on gestational age, maternal preferences, and specific surgical risks, generally not indicated prior to viability or procedures with minimal maternal cardiovascular impact. Continuous monitoring is recommended for high-risk procedures with significant cardiovascular instability and if it's feasible. Looking at anesthetic and medication challenges, as we talked about, there's effects to the heart rate and the variability, and anticipated changes should not routinely prompt delivery unless there's significant concerns. And the monitoring should guide maternal treatments and be feasible without compromising maternal health. And that's actually a really key statement here. There's nothing that we should be doing, worrying about this second person, that gets in the way of taking care of maternal health, knowing that maternal health really is the basis for that second person's well-being. It's as well as it's the right thing to do. You never want to compromise maternal health because you're worried about monitoring. Necessary equipment and personnel need to be present, and the monitoring involves preoperative and postoperative assessments with intraoperative monitoring for high-risk cases. And so she has a little bit of an algorithm here, and I'm not sure that's going to be that helpful to go through that. But there, at the end of the day, what they recommend is that the procedures with high risk of maternal or cardiovascular instability with hypotension, hypoxemia, such as severe sepsis, cardiovascular procedures, or something neurosurgical, continuous operative monitoring should be considered. And again, considered. And that's about as strong of a statement as really they get. So how do you actually monitor intraoperatively? Well, again, you have to be able to get at the uterus. You have to be able to perform a C-section, because if you're going to monitor, you've got to do something with that information. If you're not prepared to do anything with that information, then we have to really evaluate what we're monitoring for. And you have to be able to interrupt that procedure. So if you're doing something delicate and can't be interrupted, then there's no point in planning for an emergency cesarean section if you can't interrupt that procedure safely. The patient has to agree that that is really what their wishes are at that specific gestational age. 24 weeks is viable, but does that mean that a mother wants actually to have a 24-week baby born if there's any, just for a suspicion of there being a problem intraoperatively? Those are very different things. And if the decision is made to go ahead with continuous fetal monitoring, you actually have to have a team present down at the OR. And it's not just about the fetal heart rate. You need an obstetrician that can interpret an NST. You need someone that can do the section, and they have to understand the gestational age with the meds, what's going to happen, intubation, be prepared for all of that, and you need an NICU team available. So if you're doing an open case, then you're going to have to do this all by ultrasound, which, again, you're not going to get variability when you're looking at ultrasound. You'll see a terminal fetal bradycardia, but it's not the same thing really as an NST. You need a full NICU resus. So think about our ACRETA setup. So that means you need a second OR set up with a neonatal warmer and that whole team. This is an enormous undertaking, and really only for particularly high-risk events. They're going to be rare. It's not necessarily a never event, but they're going to be really uncommon. And they're going to, unfortunately, maybe be useful at times when you don't have a lot of time to get it all set up, such as, a severe trauma. And then maybe with that trauma, there might be something that actually does evolve in terms of abruption following blunt force. But maternal care, again, must not be compromised or delayed for this. And that's really the risk when we go too far down that path. So in summary, really the most important principle is communication between teams and collaboration and coming up with an interdisciplinary approach that takes care of the maternal needs. Now, in terms of what we've used in Saskatoon for guidelines, so I actually took a look. It's not in the SHA policies, and that's because there wasn't an SHA in 2017. SHA came into existence in late 2019. This was reaffirmed last year. It's never really been made into a work standard that was properly circulated, and that work is ongoing right now. So less than 20 weeks gestation, our standard is that the procedures or admissions are to be done at the hospital with the service most appropriate for that intervention. Beyond 20 weeks gestation, if a procedure can be done at RUH, there's readily accessible obstetrical neonatal services, and it's advised that there's a consultation with obstetrics. After the surgery, they can be admitted to the prenatal unit, before and after surgery for assessment. When the site or service or equipment is not available at that site, then the patient has to go to another site. So urology is a classic example. There is no place you can really do urology well other than the St. Paul's Hospital. So in that case, the patient will be admitted to the prenatal unit under the care of an obstetrician. Consultation with the appropriate service will happen. The plan for monitoring of the mom and baby will be documented. The patient goes to that site near the time of the procedure, and after they've completed their PACU stay and met discharge criteria, they come back to the prenatal unit for observation. The patient can then be discharged by the obstetrician after an appropriate period of monitoring, pain control, and that assessment. Generally, women having non-obstetrical surgery greater than 20 weeks aren't day surgery candidates. That being said, there's going to be special cases that arise, and this just needs to be an ongoing discussion. There may be very reasonable things, and again, I don't know what other services do, but if you're doing a block and fixing a hand, that may be a very reasonable thing to do at St. Paul's, where you usually do those things. But just that discussion piece is what really needs to happen.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.